There are many other issues and problems that occur other than nausea and vomiting for these cancer patients, and to realize that this can not only affect their weight and their nutritional status, but their quality of life, their overall quality of life as well.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with ONS member Kara Freedman, Clinical Nurse Specialist at Memorial Sloan Kettering Cancer Center in New York, about nursing management of gastrointestinal complications. Kara authored an associated chapter in the latest edition of ONS's Cancer Basics book. This episode is part of a series about cancer symptom management basics. The others are linked in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Kara.
Thank you so much for having me, Jaime.
So to start things off today, can you give a brief overview of some of the common gastrointestinal complications that can occur in patients with cancer?
Yeah, so as we know, there are many possible GI complications that go hand in hand with patients with cancer. We have complications of the mouth or oral cavity, such as xerostomia, also known as dry mouth, mucositis, dysphagia, or difficulty swallowing, and other complications we see like nausea, vomiting, diarrhea, constipation.
So first, let's start with xerostomia, also known as dry mouth. So what causes this and how is it typically treated?
So most commonly, we see xerostomia affecting head and neck cancer patients, especially those patients receiving radiation treatment where their salivary glands are included in the radiation field. We might also see xerostomia in patients receiving chemotherapy treatment or surgical procedures that cause damage to the salivary glands. And in the cases of chemotherapy, we'll usually see xerostomia resolve within the first few weeks of treatment. Xerostomia is usually permanent in patients that are receiving radiation treatment. This depends on the total dose of radiation treatment and the location of the primary tumor. So if they have radiation really close to their salivary glands, you can bet that there is most likely going to be permanent damage and they're going to be experiencing dry mouth for life. So typically we treat xerostomia with diet modification. So education is extremely important for these patients. And we really want to focus on mouth care, mouth rinses such as sodium bicarb, and even in some cases, acupuncture has been noted to be helpful as well.
That's really interesting. I mean, from your description, clearly patients receiving all modalities of treatment have potentially some risk, though certainly, as you stated, those that are getting targeted radiation therapy that involves that field where the salivary glands are, they're at the highest risk for the most severe and potentially permanent outcomes. It's something that all nurses need to keep in mind with patients who are on active treatment, just identifying what that patient's unique risk factors are and being able to, as you said so importantly, giving them education and awareness and letting patients understand what their likely outcome might be given their treatment and their cancer diagnosis. Let's dive a little deeper into that. You mentioned some diet modifications, mouth rinses, things like that. So what are those nursing implications and interventions that we should consider for xerostomia with our patients?
So yeah, oral hygiene all the way. And it's really important for nurses to educate their patients to be seen by a dentist and increasing those visits more frequently before, during, and after treatment, as well as while at home. Patients need to be aware that they need to continue this oral care using fluoride treatments and, like I mentioned, frequent mouth rinses. This is because patients that have dry mouth have a much higher risk of developing dental issues like cavities and things of that nature. So it's really important for the nurse caring for the patient to assess their food intake and their ability to chew and swallow. If you think about it, patients with dry mouth will experience changes to their sense of taste as well, which again affects their eating and can lead to weight loss and malnutrition. Nurses can help combat this by teaching the patient some other diet modification strategies, such as avoiding alcohol, caffeine, avoiding tobacco, smoking, and medications that are known to cause dry mouth, like antihistamines and decongestants and stuff like that. Also, really important to limit spicy foods, acidic foods like tomato sauce or orange juice. Also, increasing fluids. We should have them consider soaking foods in liquid to moisten it before eating. The plus side to this is that it could also increase calories by soaking it in a broth or something of that nature. Also, remind patients to avoid overly dry food, sticky or crumbly food, and really anything like that. If they're really feeling uncomfortable, we like to offer them throughout the day for them to have sugarless gum or candy, and other strategies that could help include considering like over-the-counter products such as alcohol-free mouth rinses, using a cool mist humidifier, and something as simple as lip balm can be a game changer for these patients. It's also important to keep in mind that decreased saliva can change your microflora, and that can cause fungal infections to form in the mouth. So it's something the nurse can anticipate if the patient starts complaining of discomfort in their mouth. That is definitely something specific to assess.
Thank you for sharing all of those strategies. I think those are things that many nurses likely have employed with their patients before, just to help guide how to improve that patient's quality of life, because I think that's really the important thing about xerostomia. Certainly there are some implications, as you mentioned, to dental, oral health, and putting patients at risk for different types of infections and things if they can't maintain that oral health. But really, it ends up being a quality of life issue for patients. A lot of people, food and drink is social, it's family, it's a way to express feelings. It's more than just a means of sustenance. And so when the ability to do those things becomes severely impacted by something that seems on the surface as sort of benign as dry mouth, it's easy, I think, to gloss over it with patients in their education, their pre-treatment education, and setting them up with the accurate expectations of what they might experience.
I love how you said something that seems so benign, but it really affects their life all day long. You'd be surprised to see how much this comes up as a complaint for patients.
Absolutely. Moving on to mucositis. Can you give us a brief overview of what this is and some of the basic preventative measures?
Mucositis, as we know, it's inflammation, ulceration, sores of the mucous membranes that affect the digestive tract. Mucositis can affect the mucosal lining from the mouth all the way to the anus. So when you are assessing your patient and you're looking inside their mouth, you can bet that what is going on in their mouth is going on in the rest of their digestive tract. It typically occurs in patients receiving radiation therapy, again, to the head and neck, and patients receiving chemotherapy as well. We're going to see mucositis in chemotherapy patients, usually around the 7 to 14 day mark. And it's also very, very prevalent in transplant patients as well. All patients with mucositis will usually present, like I mentioned, with blisters, ulcers, cracks, swelling, redness. Their mouth is just going to look really raw and really uncomfortable. They might have whitish lesions, and they'll definitely present with pain throughout their entire mouth. The problem really occurs when the pain is so bad that they're no longer able to perform the adequate mouth care that we've already educated them about and the importance, of. And it's at that point when they can no longer do the mouth care is when the mucositis is going to be at its worst. It could lead to bacterial, viral, fungal infections, and that can affect the entire GI tract as well. It's really super, super critical for us to understand the type of anti-cancer treatment that these patients are about to receive So knowing the patient's individualized plan is going to help us in caring for these patients and forming some sort of preventative plan for them in order to avoid the mucositis. So before patients begin their treatment, once again, the dental exams are really a must. We want to make sure that we're identifying any sources that may cause trauma, such as sharp teeth, dentures that don't fit properly, patients that have braces. These are things we want to think about because once their mouth gets really sore, they could be sources of infection if they get cut on one of these things. And similar to xerostomia, preventative education, we're going to be talking about oral care, brushing with a soft bristle toothbrush at least twice a day, flossing, as long as a patient isn't thrombocytopenic, performing mouth rinses. You're going to hear me say this over and over again, but 4 times a day is the golden number, if not more. But at the very least, we want to do these non-alcoholic rinses or sodium bicarb rinses. They can be made right at home, but it should be done very often. There are also preventative medications that we give prior to certain chemotherapies. So once again, really understanding the treatment plan is at the utmost importance for the nurse. We've seen patients chew on ice chips during their chemotherapy. It's a form of cryotherapy to cause vasoconstriction to the area to prevent mucositis as well.
And I think you've mentioned and done a great job of emphasizing, but let's just talk a little bit more about the notion of prevention. Well, a lot of the side effects that we talk about is just in cancer care in general. There are some treatments that can help to relieve the symptoms once they appear, but we know that in some situations, such as mucositis, prevention is key. So can you talk a little bit more about the importance of prevention in mucositis?
Yeah, I can't express this enough, like how important it is. And we know there are many ways to lessen the severity, if not prevent mucositis altogether. But once a patient develops this mucositis, it could lead to dose reductions of chemotherapy, delays in treatment, never mind the discomfort and its negative effects. Really, what we are honing in on is the fact that we want to prevent these patients from having their mucositis be so bad that we have to stop their treatment. And what does their cancer look like at that point? If we're stopping treatment because of that, they can't continue. So it's really something that we want to focus on.
When I think about mucositis, I think we've all had a terrible sore throat, or maybe, when you were younger, you had braces and you had a canker sore from that irritation. So just trying to think through as our patients are coming into treatment without familiarity of what the side effect will be like. I think mucositis might be hard to understand because most of us, hopefully, thankfully, have not had anything as hard as mucositis is to deal with in a broad state. Again, we might have the isolated canker sore, the sore throat that lasted a few days, but this is a different scale, potentially the entire mouth, the tongue, everywhere. And just because it is so hard, I think, to relate to that, unless you've had the unfortunate experience of it, I think it's just important to continue to impress how important that prevention is, as you mentioned, because it's just something that is, I think, surprising to some patients. And, I've talked about this in other episodes before, but I think collectively the public, thanks to media and however cancer has been portrayed, they always assume nausea and vomiting. That's the worst of the worst. And certainly that can be terrible. It's these other side effects that we don't always have a great way to treat them once they appear. And so these are the ones that I think are not as well known. They might go under the radar. We really have to emphasize, not to the point of terrifying our patients, but help them understand really the things we do before it happens can have a huge impact on how well you can manage it, how severe it might potentially get, the impact it has directly on staying on treatment, staying on schedule. All of those things are important. So it's a balancing act of emphasizing the importance and not completely scaring the daylights out of your patients and their families. Let's just talk a little bit more in depth. And some of this might sound familiar because there are some, I think, overlaps between xerostomia that we already covered and mucositis. But let's talk about some of the nursing implications for treating this side effect.
Yeah. So once patients develop mucositis, we want to let them know that it is still good for them to be doing these mouth rinses. They might want to have nothing to do with things in their mouth, but it will help with the pain and it really helps keep their mouth clean. So this is something that's super important. Also, eliminating irritants from their diet. So we mentioned before, but the alcohol, tobacco, acidic, spicy foods, also foods that are really hot or really cold, this is going to really affect them and cause a lot of pain if they are experiencing mucositis. Even in moderate cases, it's still going to be pretty painful for them and it could cause it to get worse. So we also want to make sure that we're not expecting patients to be able to take medications orally at this point. Once they have mucositis, we're looking more towards alternative routes like rectal, IV, or even transdermal. So you'll see a lot of patients with mucositis being treated with fentanyl transdermal patches. And we do see pretty good outcomes with pain management with the transdermal patches.
Thank you for that. And I think, again, that's one of those things that I don't know that it even registered in my mind as we were talking. I'm focusing on food and them being able to maintain nutritional status. But then it's like, well, if they can't swallow food, they also can't swallow any of the medications that they need to take, whether it's for their cancer diagnosis and the treatment, or if it's just other comorbidities that they need to take maintenance medications for. And so I think that's just another layer of importance of how critical it is to try to avoid, mitigate, lessen the chances of, or at least minimize the impact of the oral mucositis. Because while all those other routes of medication administration might be possible, they might not. And those are also not always as convenient or desired to use those alternate routes. So I've had patients in my clinical career where you can tell that they try to minimize things. They don't want to speak up because maybe they don't want to get off track, or they feel like if I have to dose reduce, it won't be as effective. And certainly we know that that's not necessarily how this all works, but we have patients that come into their treatment with some of those preconceived notions. And so it's important to emphasize that they have to bring those things up. We don't see our patients every day. Now, when they're getting radiation, we do. So that gives us a more frequent opportunity to ask pointed questions, do an actual physical assessment, look in their mouth, make sure we don't see anything concerning, even if they maybe don't subjectively feel it. But for patients that are getting maybe chemotherapies that are on a 2 or 3 week cycle, we're not seeing them as frequently, giving them that permission of, you're not bothering us. We need to know. Please tell us as soon as you notice this symptom start. The sooner we can catch it and maybe ramp up our efforts, the better.
Right. Preparing our patients, like you mentioned before, not scaring the daylights out of them, but preparing them for what to expect and really when to contact us, and not to wait until it gets too severe so that it's even harder to treat. We really do want to make sure that we're driving this home when we're educating our patients and educating our nurses, when we have a new nurse to the oncology field. And it's really important to talk to them about these specifics.
Absolutely. And this is the type of side effect that has interventions that are squarely within the realm of independent nursing practice. This is wellness promotion. This is self-care. These are things that don't require a prescription and a prior authorization. These are things that we can teach our patients to do to care for themselves, and giving them those tools, as well as, again, the permission to communicate with us, status updates, how they're doing, how things are changing. That only just strengthens and bolsters the trust in that relationship with patients, so that they feel like we want to hear from them and we want to be able to help intervene as soon as possible. It's not all doom and gloom for mucositis. Recently, I've seen that there's a new drug in the pipeline. It's called a vasopasm, and it is actually an infusion that is given daily, Monday through Friday, before a patient with head and neck cancer gets the radiation treatments. And so still in the approval process through the FDA. It is not approved yet. We'll include a link in our episode notes about the status of that approval in the FDA system, but really exciting, showing some really promising outcomes for that patient population, really improving and decreasing the rates of oral mucositis in that head and neck population. So maybe we'll turn a corner and we'll see some actual helpful therapeutics to involve in this fight against this side effect as well.
That would be amazing, because these head and neck patients really do suffer with this. And to have something that we can give them prior to receiving treatment would be really promising for them.
Absolutely. So kind of in the same realm, let's move on to dysphagia. Can we talk a little bit about dysphagia and its treatments or therapeutic options that we have to help with that difficulty swallowing?
Yeah. So dysphagia is diagnosed when we have a patient that experiencing difficulty swallowing, difficulty with the transport of food or liquids from their mouth down into their stomach. We'll usually see this occurring once again, the head and neck patients, but also patients with cancer of the esophagus or lung cancer. There are even a few different types of dysphagia that we have. We have malignant dysphagia, which is caused from the narrowing of the esophagus due to tumor involvement. We have treatment related dysphagia, which is usually caused by radiation to the field around the esophagus, the throat, and chemo. Chemo is usually reversible if patients are experiencing dysphagia, but we will see more detrimental effects to patients that are receiving radiation treatment to the area. Other symptoms of dysphagia that we see in cancer patients could actually be caused by infections like candidiasis. And this could cause the patient to have issues with swallowing. So, as for treatment of dysphagia, it really depends on the cause. But in most cases, we'll see patients receiving IV pain meds that help with the pain of swallowing, IV hydration. We have patients that aren't able to take in as many fluids as their body needs. And we need to combat that with IV hydration. Also, once it gets to the point of they're not able to take in food, we are going to have to look at enteral feed options or TPN, as we know that comes with its own risks. So it would really have to be like a risk versus benefit type of thing. And if we think that that is going to benefit the patient, then it's definitely something that we are going to go forward with. Our goal as nurses should really be to help the patient learn swallowing techniques and exercise those muscles so that we don't have to get to the point of TPN or anything like that. So nurses should be able to teach the patients specific strategies like tucking their chin or rotating their head while swallowing. This will effectively move the food toward the esophagus, and teaching them specific swallowing maneuvers, like I mentioned, to help strengthen the muscles. Other interventions that the nurse can anticipate are mechanical, like surgical interventions, such as dilation or stent placement. So that would be more for a malignant dysphagia. Really, we should also, I'm going to talk about this all day, but counseling patients on their dietary changes that can help manage this. So in the case of difficulty swallowing, we want to encourage patients to eat soft, non-sticky foods that are easier to chew and swallow, as well as thickened liquids, because this does help create that bolus and allow patients to swallow. It also decreases their aspiration risk, which is a big risk for these patients. You know, we really do want to focus on educating them about ways to prevent aspiration, sleeping on an elevated pillow, exercising their muscles using the techniques mentioned before, adding liquid to their food can also help soften the food so they could have a better chance of swallowing it without issue. And also educating patients about the risk of malnutrition, which we've mentioned. But as nurses, we know dietary suggestions that we can give them. But if we are finding that the patient needs a little bit more help, reaching out to our local dietitian could really help benefit the patient in a positive way.
Absolutely. And that's exactly where my mind was headed listening to you just talk through. I mean, a lot of our conversation, we've used the head and neck patient as the example because certainly they have a very complex course in terms of their therapy, their treatment, their recovery. You know, we've talked about lots of sort of orally associated side effects, the xerostomia, the mucositis, now the dysphagia. And there are parts of this that I do agree with you. Nurses we know this or we can learn this. We can provide some of that baseline education preventatively. But I think we also need to understand and respect our colleagues that are also specialists in this same space. You mentioned, nutrition, dietary consultations or referrals, our colleagues in speech and language pathology or OT to help with some of those swallowing techniques and being able to provide that additional education, especially when someone is actually suffering from some of these complications. And so, understanding who are your partners in this caring for these patients comprehensively, just know who they are, get to know them, understand how they take care of those patients. And then you might be able to ensure that the patients are then referred to those services at the best point of time. Maybe it's even before anything happens at all, so that they can establish that relationship. If we know that it's a 99% chance that this patient is likely going to have swallowing difficulties, well, then just set them up ahead of time, get them already in that specialist's cohort so that they can already get a quicker appointment so that they can have the care that they need at the time they need it. So a little bit of thinking ahead and planning and coordinating care and across those transitions. So this one needs no introduction, but we're going to introduce it anyways. We're going to round out to our discussion today with nausea and vomiting, which we all know society at large assumes that everyone getting cancer therapy suffers from this, though we know that's no longer true. So nausea and vomiting, very common, but also treatable. So let's talk a little bit about the different types, the way that we define and kind of separate the different types of chemotherapy-induced nausea and vomiting.
So nausea and vomiting caused by chemotherapy occurs in more than 80% of patients receiving chemotherapy treatment. So much so that we have delved even deeper into this about the different types and when they occur. So we have nausea and vomiting due to chemo that occurs in the acute phase. So this is after a highly emetogenic chemo where nausea and vomiting is expected to occur during the first 24 hours after a chemo treatment. Then we have delayed chemo-induced nausea and vomiting, and this occurs as a delayed response, obviously, that can persist for a number of days after treatment. And then we have anticipatory chemo-induced nausea and vomiting, which is like a conditioned response stimulated by sights, sounds, odors. The patient walks into the infusion center and gets nauseous and maybe even vomits. And that's just because of their senses, of where they are. Interesting that we actually treat them with different regimens. The acute nausea and vomiting might be treated differently than a delayed or an anticipatory. For example, the delayed nausea and vomiting is more of a around the clock care rather than the acute, which is more of a faster acting, like an IV antiemetic.
It is so important to keep those different types of chemotherapy-induced nausea and vomiting. CINV is the acronym that we see a lot in the literature and much easier, less of a mouthful to say. But, it is important to consider not only what the therapy the patient is on, but when they could experience their side effects of nausea and vomiting, because we hope to not have to see it or have them experience it for us to then know when it's going to be. Right? We've thankfully come a long way to now be able to predict which drugs will cause which. So let's talk a little bit about that. What types of treatments are typically the most notorious for causing this nausea and vomiting, and how do we sort of keep them organized in our heads?
The American Society of Clinical Oncology, ASCO, which many of us know it by, they provide a summary of IV chemos and their respective risk. So we see high risk chemos, and then they have moderate risk and mild risk, and they're all treated differently. So our high risk chemos are predicted that 90% of patients will experience emesis. For example, we have cisplatin, our cyclophosphamide, carmustine, dacarbazine. We also have high-risk oral chemos. Procarbazine is one of them. It's really helpful that ASCO provides us with these summaries because it really helps the nurse to anticipate, okay, I can look at the list of my high-risk emetogenic chemos, and I can anticipate that my patient is going to need the specific pre-chemo antiemetic or multiple antiemetic drugs prior to even receiving their therapy.
Absolutely. That's great advice. The ASCO guidelines are certainly important. NCCN has a whole guideline dedicated to nausea and vomiting management and risk identification. So as you mentioned, there's tables that list, they can't be current down to the every minute of every day, but certainly as new drugs are approved, as updates are made to those guidelines, they try to then include. ONS resources also include duplications or republication of these similar tables just to give multiple sources of guidance for nurses to understand as they see these new drugs coming, what is their metagenic potential? Which category will they fall into? And as you mentioned, once was a time where we had like maybe a handful of oral drugs. Well, now the oral table is probably as big, if not bigger than the IV table of drugs. And so just understanding where that class of drugs lives on the table, again, as new drugs are being approved so frequently, it's hard to keep up. And that's something that I think we are trying to help wrangle in at ONS to help our nurses, our members. But if you understand the class of drug that a new drug is approved in, then you can feel pretty confident that it's likely going to fall into maybe a similar category of metagenic potential. But again, always want to check the table if it's updated just to have that point of reference, because then that lets you then cross-reference, okay, if it's in this table, do they have the right medications ordered to be given for their IV administration or at home as a prescription? And so it informs both preparation for their day of treatment as well as what they will have on hand to manage their symptoms when they go home.
Yeah, definitely. It is quite the table, as you mentioned. It has so much information, but such helpful information for clinicians that are looking to make sure that their patients are getting the best possible preventative care. As we've had nausea, vomiting, one of the biggest, worst side effects, it's really nice that we have these resources and they get updated so frequently that it's like just really helpful to have them.
We certainly know that the drugs themselves are a risk factor that will influence the potential for nausea and vomiting, but there are some personal risk factors that patients themselves might bring to the equation. So let's talk a little bit about what those risk factors are that we know that would potentially set up a patient to experience worse nausea and vomiting with their treatment.
Age actually affects patient risk. Age 5 to 60-year-old patients are at a higher risk for suffering from CINV. Females, also a history, obviously, of past chemo-induced nausea and vomiting. If you were pregnant and you had nausea and vomiting during your pregnancy, you are at a higher risk for experiencing this with your chemotherapy. Patients that are higher risk for anxiety, we see more nausea and vomiting induced by chemo. And then patients that don't use alcohol also are more sensitive to these chemos and the effects of the nausea and vomiting.
That's so interesting. And again, important as we are getting to know our patients. We know that the provider has ordered their treatment plan. We've already looked at the table. We know where those drugs will land and we can predict what category of a metagenic potential they might land in. But some of these unique individual risk factors might help push the deciding factor of what antiemetics we give. Sometimes they're like, well, it's moderate, but it might be high. And so if you know a patient checks off 3 or 4 of these boxes of kind of personal risk factors, then that can help you as the nurse advocate to say, Mrs. So-and-so, she reported this history of, she had really bad morning sickness, for example. These are things that might help you at least initially adding on the PRN medications that can be ordered alongside what is the typical regimen for antiemetics. So let's get into management. And we know there's huge tables that guide us, algorithms and trees that go into other trees of advice. So what are some of the tenets, I would say, of nausea and vomiting management?
We definitely touched on the importance of using those resources, but it's also important to understand that patients will also experience breakthrough nausea and vomiting, which is sometimes even harder to treat because patients have already been taking their pre-chemo meds, their, pre-meds during the treatment, and then the medications that they're supposed to be taking around the clock. So my advice and all of the guidelines advise us to give medications from a different class from what they're currently taking and to continue the around the clock treatment, because these tend to work better than a PRN where the patient is already experiencing the nausea. It doesn't help as quickly. Also considering routes, obviously, other than oral. We wouldn't want to be giving a nauseous patient a pill to swallow. So anticipate the use of transdermal, IV, or rectal medications. We also have non-pharmacological management. So things like acupuncture have been really helpful in preventing or managing nausea and vomiting. Avoidance of strong smells, behavioral therapy, relaxation, hypnosis, guided imagery, music therapy, all of these things that we as nurses can help educate the patient about. If medications are working, but they need just a little bit extra help. Also, cognitive distraction, like virtual reality goggles. I know we have them here at MSK. They can help distract the patients during their treatment when they're getting these acute episodes of nausea and vomiting. So we've really, I want to say, like, thought of everything with trying to manage this complication.
We're still combating the perceived expectation again of that everyone's going to have it and everyone's going to be miserable. We have to continue to educate our patients, their families. Those are important expectations to understand. Ask the patient, what do you expect? What is your familiarity with getting cancer treatment? Well, let me tell you about your specific drug. We expect that it might cause moderate nausea and vomiting. So here's the drugs we're going to give you. We're going to give you 3 drug combination, just helping to explain the comprehensive nature of how far things have come. I started my oncology practice after the revolution of ondansetron. Before ondansetron, it was awful. And that really, I think, kicked things off and set the stage for all these other classes of drugs that can address both the peripheral pathways and the central pathways to what we now understand is causing this chemotherapy-associated nausea and vomiting. I think just trying to explain, our patients that are still concerned are very anxious about this. I think it's really important to help them understand like how many weapons we have now in the arsenal to help. And as you mentioned, knowing what their drugs are from the beginning, understanding if they're getting a 5-drug regimen to treat their cancer diagnosis, well, whatever the highest emetogenic potential, we treat to that one. Even if on other days they're maybe not getting that one, you treat to the highest, letting patients know we have options if you still have delayed or if you have refractory. We have other things that we can do to help address their nausea and vomiting.
Once again, educating patients to speak up. Like if they are experiencing more symptoms certain days or certain times, to discuss that with their healthcare team so that we can come up with a plan. It's really about individualizing care.
Absolutely. Well, one final question that we've touched on, I think, on the individual side effects, but I still think it's worth reinforcing is that, we know a lot of the GI side effects that we've talked about on today's episode can potentially create weight loss, malnutrition. So what are some interventions that nurses can use to help provide support to help maintain a patient's nutrition status as they're going through their treatment?
Yeah, so making sure patients are really well educated on medication regimens prior to their treatments are occurring, and really focusing on the fact that it's really important for them to adhere to the preventative measures that we have lined up for them. We've mentioned before, but conducting that nutritional assessment as a nurse, but also collaborating with dietitians, nutritionists can really, really help us as well.
Absolutely. I love that. As I went off on my tangent before, I think, knowing who our colleagues are, knowing who our teammates are, knowing our own limits, and making sure that we call in, make those recommendations for referrals when it's going to be a need or it already is a need. I think those are important tools for us to keep in our toolbox so that the patient just gets the highest quality and most comprehensive care that they can get, especially when they're dealing with severe side effects or just a multitude of side effects. The more support we can provide, the better.
Right. And it takes a village. We're not siloed by ourselves caring for these patients. The patient will benefit from the more support that we give them. And as nurses, that's really one of our many, many jobs that we do, but is to make sure that we provide them with as many resources as we can.
Absolutely. Well, Kara, thank you so much for your time with us today. As we approach the end of the episode, we always like to wrap things up with a few kind of quick fire questions just to summarize maybe the important points we've talked about today. So to start that section off, what are some common misconceptions about gastrointestinal complications?
So some common misconceptions about GI complications, we already touched on this really, is just thinking that cancer patients are only going to experience nausea and vomiting. As we mentioned, there are many other issues and problems that occur other than nausea and vomiting for these cancer patients. And to realize that this can not only affect their weight and their nutritional status, but their quality of life, their overall quality of life as well. So it's really important to just make sure that we are looking at the whole patient.
Yeah, thank you for that. I agree. What's something about this topic that's not often discussed, but you wish people knew more about?
It's a really great question. I really want to drive home just the importance of preventative measures and educating patients. It's really important to have our patients be armed with as much knowledge and education prior to going into their treatment as possible. And we know that the whole experience for these patients, and well, all throughout, but I was going to say in the beginning, is overwhelming. So not only, explaining the preventative measures to them in the beginning of the process, but also throughout. Like, we want to make sure that we're educating them, because something that we say in the beginning of their treatment journey might resonate differently with them in the middle or the end of their journey. So really making sure that we are taking care of these patients and keeping an open communication with them throughout.
I love that. And I agree. I think education is never a one and done. You will feel like you're repeating yourself because you are, but you need to. That's great advice. What about additional training or education? What do oncology nurses need to help better understand the GI complications?
For our more visual learners, I would say any oncology continuing ed classes that might be offered by your place of work or the hospital that you work at could really, really be helpful. Since GI complications are so broad, you will see these types of complications in really any oncology setting. So if you feel the need to, you work in a surgical oncology floor and you want to go and shadow in an infusion unit to understand hands-on, more specific complications, you will see that more in an infusion unit. So I would say that could be really helpful to do for more of like our hands-on learners.
I think that's a great idea. And really for any side effect, just to understand how it might be experienced or managed across a patient's treatment trajectory, wherever they land within our various oncology departments, it might be identified differently, treated differently. And so I think we have a lot to learn from each other, all for the betterment of the patient. And then what are some additional resources for patients and providers who want to learn more about this side effect?
We mentioned the NCCN guidelines. Those are so helpful, full of information. National Cancer Institute, NCI, also has really, really great resources for both patients and healthcare professionals to access. And it's really easy to access online. Not to mention our very own textbook, the Cancer Basics. I feel like that would be a really great resource as well.
Well, Kara, thank you again for sharing your time and your expertise with us. Do you have any final comments to share with our listeners today?
Thank you so much for having me, first of all. And also, just keep up doing the good work that you do. Us nurses, have been through a lot in the past couple of years, and I feel like our focus is on really good patient care, and we see you. So just keep it up.
Absolutely. Thank you so much, Kara.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.